is well and safe. First, I would like to say thank you to the CCEO COVID-19 Ad Hoc Committee for initiating this lecture series. It actually, shed some normalcy for all of us during this unfortunate lockdown, so thank you. So today I will be discussing the evaluation of patients with ptosis. Majority of patients you will see in your practice are those of the congenital and the involutional type that comes with age. For the congenital type, we want to correct the ptosis to avoid amblyopia. For the involutional type, we correct because of cosmesis or functional visual loss. However, you might miss some milder forms like the picture on the right. A picture like this would be described by my mentor, the late Dr. George Camara, as having ILE, which stands for involutional lateral entropion. It is a physical finding that is common to Asian eyelids, where only the lateral portion of the upper eyelid skin turns inward. And because of that lateral skin hooding, it can actually cause symptoms of irritation and pulling of tears on the lateral canthal area, and even sometimes they complain of loss of peripheral vision. The picture on the left is your classic BPES, or your blepharophimosis syndrome, which consists of the three features: your B for your blepharophimosis, P for ptosis, and E for epicanthus inversus. You'd be surprised that ptosis is more common than you think. Please bear with the following pictures, as I cannot put all my patients' photos in this kind of presentation. No? So not everyone, though, is bothered by it. Some don't mind a little asymmetry, and some mask the condition with spectacles, and some just don't give a shot at noticing. Okay, I'm sure you will like my next slide better. I mean, for the ladies in the house. You are just in your houses, right? So during this lockdown, I came to know these two men. But anyway, before we head on to the evaluation of the ptotic lid, knowing the eyelid anatomy is necessary. And it is so apt to show you that these two men represent the classical eyelid of an Asian and a non-Asian eyelid. Although we all know that there are differences in the upper eyelid of different races, the sequence of layers are still the same. So let me try to show you that you will always have the skin, and then your orbicularis muscle, and then your orbital septum before you reach your preaponeurotic fat pad, which always lies anterior to your levator aponeurosis, and your Mueller's muscle, and this is your tarsus, and then your conjunctiva. So they're the same. So your preaponeurotic fat pad will always be your landmark, as it lies anterior to your levator aponeurosis. Okay. For ptotic patients, identifying the levator aponeurosis is key. The dermal attachment seen in this diagram for the levator aponeurosis in Asians is naturally lower than that of an eyelid that is non-Asian, with a very apparent lid crease. As Dr. Robert Goldberg of UCLA would say, this would be your tarsal platform show. So in young patients and younger adults, the levator aponeurosis is more easily identified. However, in older patients, some aponeuroses are very thinned out and infiltrated with fat. So ptosis can be classified into these categories. You have the levator maldevelopment ptosis, which usually appears at birth. Your myogenic ptosis, which is associated with other systemic myopathies. Your neurogenic ptosis, where it involves the oculomotor nerve aberrations in your oculomotor nerve innervation. And the very common aponeurotic ptosis, which are common in the elderly population, hence the term involutional. Your mechanical ptosis, which are caused by your eyelid masses and cicatricial causes, and your pseudotosis. But for the purpose of this lecture, since majority of the cases you will see will either be congenital or acquired aponeurotic, we will focus on these two types. So there are 4 essential parameters to evaluate the ptotic upper eyelid: palpebral fissure height, margin reflex distance, levator function, and your skin crease height. The palpebral fissure height measures the vertical height between the upper and lower lid margins centrally as the patient looks in primary gaze. Some surgeons would also take this measurement in an extreme up gaze and extreme down gaze if they're very particular with minimal leg ophthalmos. They want to check for it. Margin reflex distance is the distance of the corneal light reflex in primary gaze from the upper lid margin, that would be your MRD1, and the distance of the corneal light reflex in primary gaze from the lower lid margin, that would be your MRD2. So as the examiner shines a light in front of the patient, make sure that the patient is fixating in primary gaze. This is what you measure. In my practice, I only measure the MRD1, which is more important. So just remember that the upper eyelid ideally is positioned around 1.5 to 2 millimeters below the upper limbus. Next is this crucial vital sign is your levator function. This is the distance of the eyelid excursion measured between extreme down gaze and extreme upward gaze. Your frontalis muscle should be immobilized by pressing on the muscle just above the eyebrow. So this is me examining this 18-year-old patient performing the levator function. I press on that frontalis muscle just above the eyebrow, ask her to look down gaze and an extreme up gaze. You may repeat this measurement just to confirm your numbers, as this will be the one that will determine your procedure of choice for management. Okay. Now for infants and uncooperative children, you cannot do the same thing as you did earlier. There is such a thing as the Eyelid test. When you avert their eyelids, so the infant becomes agitated, right? If the lid does not revert back on its own in its normal position, then poor levator function is certain. I mean, if you want to do that to your younger patients. So again, the levator function determines the surgical approach for treatment. Next would be your lid crease. In the books, they say that the average tarsal height of the upper eyelid is 9 to 10 millimeters. This is probably true with Caucasian eyes or non-Asian eyes, but in a study done by Dr. Camara and yours truly, the average central tarsal height of Asians appeared to be around 7 millimeters. So remember that the eyelid crease is formed by the action of the anterior third of the aponeurotic levator fibers. It is absent to minimal in cases with no levator function, and it is high or abnormally elevated when it indicates a disinsertion or dehiscence of the levator aponeurosis. So the height and contour, I always take note of that. I compare it to the contralateral normal lid if the ptosis is monocular. But I also measure it intraoperatively, and this is how I do it. So before doing my incisions, I avert the upper eyelid and I use a caliper to measure the inferior border of the tarsus up to the superior border, just below the upper lid margin. So most of the time, this will correspond to the measurement of the lid crease that you will see on the contralateral non-ptotic lid. But for bilateral ptosis, this measurement determines my skin incision. So measuring the lid crease is important for two reasons. It can give you a clue to the type of ptosis, and it provides the location of the standard incision line of opening up that lid. So I made this table for you to easily compare the different degrees of ptosis. This does not mean that an MRD1 that almost completely covers the corneal reflex cannot have good function. On the contrary, acquired aponeurotic ptosis can have severe MRDs, but will show you a good levator function. So that's just a summary of the measurements of the possible measurements. So again, the levator function among these four parameters will be the determining factor for the type of your surgical approach. Okay, so again, to give you a summary of the differences between a congenital and an aponeurotic ptosis, both can range from mild to severe ptosis, but in one that appears early at birth, you will hardly see an eyelid crease, okay? And one that is acquired in old age, you will notice a higher than normal lid crease. The levator function will be reduced in your simple congenital ptosis, and in your acquired aponeurotic ptosis, this will be near normal. When you ask the patients to look down gaze, you will observe an eyelid lag for the simple congenital ptosis and an eyelid drop for the acquired aponeurotic ptosis. Yeah, these pictures will give you a better understanding of the differences I just stated in that table. So if you would notice, no eyelid crease and a higher lid crease for the older patient. And when they look down gaze, there's supposed to be an eyelid lag for the ptotic eyelid on the younger patient and an eyelid drop on the left upper lid of the older patient. Again, an eyelid lag for congenital and an eyelid drop for the acquired aponeurotic. Eyelid lag means the eyelid margin is higher than the contralateral non-ptotic eyelid, and the eyelid drop is lower than the non-contralateral eyelid. So my physical exam does not stop there by just taking the eyelid vital signs. There are other signs I look out for when evaluating these patients. A head tilt or chin elevation will show you how patients compensate as their ptosis affects their vision, their function. And for older patients, deep forehead wrinkles and asymmetry of brow height can be observed as evidence for overaction of the frontalis muscle to help lift that ptotic lid. So you can see that even that eyebrow is higher than the normal eyelid on the right. I also check for lagophthalmus, tear film, quality, and Bell's phenomenon. So since these may predispose patients to complications after surgery, as dryness and exposure keratopathy. As evidenced in one study and with my humble experience, lagophthalmus will really be present after ptosis repair. Although it should decrease as the healing continues, there will still be a residual lagophthalmus in some patients. So in this study, they concluded that the pre-existing scleral show, lower scleral show, and final height of the eyelid following surgery were significant predictors of post-operative lagophthalmus. Now, what about the Bell's phenomenon? This is the protective physiologic mechanism where the eyeball goes upward and out whenever a patient closes her eyes. This is also worth noting, especially if there is some scleral show or lagophthalmus. So you might want to add some horizontal tightening procedures in your pre-op plan, if that's the case. And lastly, I pay particular attention to the pupils and synkinesis for myogenic and neurogenic types of ptosis. Other pointers, I request for previous photos. So these previous photos serve as proof if they're not sure if this was an acquired or a congenital type. It gives me an idea what the patient looked like before or how much it progressed through time. Some would even request that they would want to look at, they want to look the same as their photos like 3 years ago. Next would be visual field testing, because some insurance companies will ask for proof of functional ptosis as they will not cover for cosmetic repair. You may request for a visual field prior to surgery. And lastly, your fatigability test. This is, I only do this when I suspect myasthenia gravis, and this will need further investigation. So just in general, there are three types of surgical correction: your external or your transcutaneous levator advancement, your internal or your transconjunctival levator tarsus Mueller's muscle resection or the posterior approach, and your frontalis sling suspensions. And all of these will be discussed in more detail by Dr. Mark Imperial in the next lecture. Thank you for listening.
Good afternoon. I hope everyone is safe. I would like to thank the PAO and the Psoprs for giving me the opportunity to give this talk entitled Keratoplasty 101 Managing the Ptotic Eyelid. I would like to commend Dr. Sandy Waraktan for an excellent lecture on the evaluation of patients with ptosis. To start, if we already established that our patient has ptosis, the next question we need to ask ourselves is, do we need to operate? Basically, the indications to correct ptosis are prevention of amblyopia and to free the visual axis. Some would tape the upper eyelid temporarily to prevent amblyopia. Another non-surgical method is using an eyelid crutch to attach the spectacles to manually lift the upper eyelid. These are temporizing measures, as surgery is the definite treatment for ptosis. Again, the primary goal of performing surgery is to permanently elevate the upper eyelid to provide free, unobstructed vision, and of course, to the delight of our patients, to restore cosmesis. As previously discussed, the main culprit here is the levator muscle. If there is dysgenesis of the levator muscle at birth, we would expect the levator function to be poor. These are most commonly seen in congenital myogenic ptosis. On the other hand, if there is weakening or disinsertion of the levator muscle, patients may have fair to good levator function, which is typical in a patient with acquired aponeurotic ptosis. These are the two most common types that we encounter in practice. The most important eyelid measurement or eyelid vital sign is the levator function. This will dictate the most appropriate surgical technique to be performed. There are numerous tables in literature that gives recommendations on what surgery to perform depending on the levator muscle excursion on upgaze. Personally, I follow the 4 mm rule. If the levator function is less than or equal to 4 mm, I do frontalis suspension. Anything above that, I do levator muscle advancement or resection. I prefer the anterior cutaneous approach. Since we need to taper the level of the upper eyelid during ptosis surgery, local anesthesia with or without sedation is preferred, sometimes making them sit down for better assessment of lid height. Of course, for children and patients who cannot tolerate being conscious during the operation, general anesthesia is utilized. We just need to inform the patient that readjustment may be necessary if results are not too satisfactory. My personal preference is anterior transcutaneous approach because of the following reasons. It gives me a better exposure compared to posterior approach. Since most patients have redundant skin, combined with upper lid blepharoplasty makes it easier to convince these patients. I usually tell my patients that the procedure has side effects, and when they ask, I will tell them it will make you look younger. It is less scary for the patient as the eyelids are most oftentimes closed. It is easier to taper the amount of elevation and is more accessible for reoperation. If necessary, the amount of levator resection will depend on ptosis severity. On the day of surgery, I usually ask patients not to use any cosmetic products as this would be removed at the operating room. Markings are done before local anesthesia is given. I usually start by marking the lid crease if present. If there is no lid crease, we can measure the height of the tarsus posteriorly to give us a gauge to where to create the new lid crease. It is usually lower in males than in females. The amount of skin that is going to be excised is then marked. Remember to leave an adequate amount of upper lid skin to prevent eyelid retraction. I usually prefer to mark with dotted lines initially and then connect to form a curvilinear line. It is also advantageous to use a fine tip marking pen or a sharp wooden stick dipped in gentian violet. It is also better to instill topical and ophthalmic anesthesia before marking as not to spread and bleed the ink. After marking, you can ask the patient to look straight to check if your markings are adequate enough. This is an example of a patient without a lid crease. These are commonly seen in congenital ptosis and in patients with Chinese ancestry. The lower lid line near the lid margin will become the new lid crease post-operatively. Local anesthetic is then injected. I use lidocaine with epinephrine. I start with small injections centrally, then wait a few minutes before I inject the rest of the eyelid. I prefer to inject below the orbicularis to hydrodissect it from the orbital septum. I usually make sure to inject an adequate amount to the medial area as it is very sensitive to pain and prone to bleed. Local anesthesia in my case is injected before prepping the patient. This is to give time for the anesthetic and the vasoconstriction to take effect. There are different ways to make skin incision. The most precise way would still be a scalpel, in this case using blade number 15. It is important to stretch the skin while cutting to prevent the skin from bunching up. The disadvantage of using cold blade is bleeding. At present, I prefer to use monopolar cautery with a fine Colorado needle or Elman radiofrequency, whichever is available. The sweeping motion of the instrument would create a fine incision with the advantage of less bleeding in the surgical field. In the present situation, we would probably limit the use of this instrument because of the fumes that it may produce. If necessary, excision of redundant skin and orbicularis is done. Our goal is to expose the orbital septum layer immediately. Next is to expose the tarsal plate. Orbital septum is then incised to expose the levator aponeurosis and muscle, which is located immediately below your preaponeurotic fat. Once the levator is identified, it is important to disinsert the levator from the tarsal plate and Mueller's muscle. I use 3/6/0 vertical matrix sutures pass from the anterior surface of the tarsal plate to the detached levator aponeurosis. If appropriate elevation is achieved, the sutures are tied permanently. For lid crease creation, I use 3 buried interrupted 6/0 sutures anchored to the levator or tarsus depending on how prominent you want the lid crease to be. I usually close the skin with continuous running suture with either Prolene or nylon 6/0. This is a case of a 45-year-old female with progressive drooping of the left upper eyelid. Note in the photo that there is frontal overaction on the left side. Levator function measured at 15 millimeters. I decided to do an anterior transcutaneous elevator advancement without skin excision. I did this case under the operating microscope, pardon the interference from the cautery machine. Incision was done using a fine-tip cautery. Then dissection is carried out through the orbicularis down to expose the tarsal plate, which is seen here. You can use the fine-tip cautery or you can use your Westcott scissors. As you can see, we have already exposed the tarsal plate with these margins. After which, the orbital septum is then identified and cut, in this case, using cutting cautery again. Unlike in illustrations, the orbital septum has several layers. After incising, you can shift to your Westcott scissors until you see a plane between the septum and the levator muscle. The best landmark would be the preaponeurotic fat, which is directly above the levator muscle. So you can see here, we have gotten a very nice plane. The white band is already your levator aponeurosis. Once you have identified, you can detach the levator muscle from the tarsus and the Mueller's muscle as seen in this still photo. So you can see here the orbicularis, tarsus muscle, and levator muscle. Now, the amount of dissection will depend on the ptosis severity. After you have dissected appropriately, you check for the mobility of the detached levator muscle. Using a double-armed Vicryl 6/0 suture, lift the eyelid away from the globe, then make a partial thickness tarsal pass approximately at the medial border of the pupil margin. Make sure the needle did not go through your conjunctiva. You then get hold of the detached levator muscle and pass at a specific area from the posterior to the anterior surface of your levator aponeurosis. Now, the height, where you initially put your sutures is arbitrary because you don't know its effect yet until you tie your matrix sutures. Tie the ends using a slippery knot. Make sure no tissues are caught in between before you tighten the knot, as seen here. Then you ask the patient to look straight and check for the height and contour. You can see here in the video that there is peaking at the medial side, medial upper eyelid. In this case, you have to release the knot and remove the sutures. Only remove one suture at a time because you need the old suture as a reference when you pass the needle. As you can see here, since we have overcorrection, I've inserted the needle slightly inferior to the original suture. Then you pass the second in the same fashion. You then again tighten the slippery knot and check for the height and contour. This is the central stitch which dictates your lid height. If you are satisfied with the elevation, the suture can be cut and permanently tied. Additional sutures can be placed medially and temporally to maintain the contour. If needed, lid crease sutures are passed using the same Varkil 6.0 suture. So I pass the suture at the orbicularis, and in this case, the levator aponeurosis. Usually I place 3 sutures, 1 medial, 1 central, and 1 temporal. I then close with continuous monofilament suture, either a nylon 6.0 or Prolene 6.0. I then give topical steroid antibiotics and cold compress for 2 days. I usually don't give oral antibiotics unless it's really needed. This is the pre and post-op picture of the patient who underwent unilateral ptosis repair without skin excision. This is another case of bilateral ptosis repair with redundant skin incision and blepharoplasty. This is a case of unilateral ptosis repair with contralateral blepharoplasty. As previously mentioned, for levator function of 4 mm or less, I usually prefer frontalis suspension. Mostly these are patients with congenital ptosis. A good analogy is a marionette where the slings are controlled by the frontalis muscle. Autologous grafts, specifically fascia lata, are still the gold standard for frontalis suspension. However, this may usually be harvested only when the child's thigh is appropriate in length, approximately around 5 years old. I personally prefer non-autogenous material. Here are some of the synthetic grafts that I have used. I have ranked them in order of my preference. Gore-Tex is still my favorite material. Unfortunately, it is not available locally. If any one of you know where I can get some, please message me. Supramid is also not available locally. For those that are available locally, let me share my limited experience. The silicone rod is less rigid than Gore-Tex and is good for patients who are more prone to exposure keratopathy. I have only used Toes Up a few times. It is flat and thin like Teflon tape. Both the Orosling and the Toes Up have straight sharp-tipped cannulas attached on both sides. Prolene may be used as it is readily available but has a great deal of memory, which means it usually returns to its previous shape after deformation. I had one patient that had Prolene extrusion through the conjunctiva. As a last resort, a DCR stent may be used, but please be reminded that it has a lumen like a tube, unlike the Orosling rod, which has none. These are the common patterns in threading the suspension material. Personally, I prefer the pentagonal shape, but I usually don't make the apex too high, usually just above the eyebrow. For fascia lata and materials without a straight needle, a right needle is used. You can perform this procedure with small, minute stabs, but I usually do a complete lid crease incision so I can create a lid crease for the patient. This video is an example of frontalis sling in a young patient using silicone rod. As you can see on the right diagram, the silicone rod is threaded between the orbicularis and the tarsus. After making 2 stabs at the upper eyelid, a right needle is passed while a lid plate is inserted to protect the globe. The rod can then be fetched, as seen here, and passed through the tunnel created. Another pass is then made from the eyebrow incision to the lid crease. The plane should be below the muscle layer and above the orbital septum as seen in the diagram on the left. So the same threading is done on the medial side. It looks very, very crude, especially to first-time residents. To complete the pentagon, the silicone rod is threaded through the forehead. After the proper lid height is achieved, the ends of the sling can be bound together with a Watzke sleeve or suture. The excess is trimmed and the stub is buried under the muscle layer and sutured. The next case is a 23-year-old female with right upper lid droop since birth. Levator function is poor at 2 millimeters. I did a frontal suspension via lid crease incision with silicone rod under local anesthesia. Okay, so after creating a lid crease incision, the tarsal plate is exposed. The silicone rod is then sutured to the anterior surface of the tarsal plate using non-absorbable sutures. Since the sling has an attached straight needle, it can easily be passed from the upper lid incision to the eyebrow using the same plane as illustrated in the picture. As you can see, no lid plate is needed as the direction of the needle is directed away from the globe. This is carried out on the other side, as you can see here. At this stage, after threading, you try to mimic the lid height by pulling on the two strands, silicone rod strands at the upper eyelid. Now, it is better to suture the eyelid crease incision at this point as it would be difficult to suture once the eyelid is elevated. Then the needle and sling is passed from the eyebrow to the forehead incision. The cut ends are secured and tucked in underneath the frontalis muscle, and the incision is closed. This is the patient pre and post-op. You can see that the frontalis muscle is overacting, lifting the right eyebrow on the left pre-op photo. Incidentally, the left eyebrow is also a bit elevated. Immediately post-op, the right upper lid has almost gone down to its normal level. We can also observe the poor blinking on the right eye. This is another case of unilateral frontalis suspension showing lid lag and lag of thalamus post-operatively. This is a 6-year-old female with bilateral congenital ptosis 1 week after frontalis suspension with Gore-Tex sutures. The level of the eyebrow have dramatically improved together with the adequate lid height. We should also be aware that it is not the result we always get. We need to be aware of early complications of ptosis surgery. This is a 14-year-old female that underwent uneventful levator repair. 2 days post-op, she was noted to have hematoma formation without any pain, blurring of vision, or diplopia. We continued the medications and observed. At 10 days post-op, the hematoma has decreased and eventually resolved. This patient had an uneventful frontalis sling with silicone rod on the left upper lid. 6 months later, the patient who works abroad sent me an email showing a granuloma superior to the eyebrow. I advised antibiotic steroid ointment and warm compress. 1 month after, another email showing extrusion of the silicone rod. She has no means of having it examined abroad. Surprisingly, she cut the exposed rod herself. After 2 months, the wound still has not totally healed. She was supposed to come home last month, but due to the present situation, further treatment is put on hold. Other common expected immediate post-op complications include lag of thalamus, overcorrection, and undercorrection. For me, it is better to have overcorrection as it usually lowers down in time, unlike undercorrection, which may usually remains the same or can get worse, obstructing your visual axis. If you decide to correct early, it should be done within the first week. There is minimal scarring and tissues can be dissected easily. This can be done in the clinic. For frontalis sling, only the forehead incision needs to be opened, exposing the cut ends, allowing us to adjust the lid height. For external levator advancement, the lid crease can easily be reopened even with topical anesthesia. To end, photos are very important in dealing with not only ptosis but other adnexal surgeries. Pre and post-op pictures should always be taken with the consent of the patient. You don't need any special equipment since everyone has a smartphone. This will serve as a learning and teaching aid for the surgeon, a verification of the patient's disorder for health insurance purposes, an aid to defense in a medico-legal case, and most importantly, to jolt the memory of the forgetful patient about their preoperative appearance. What I do regularly now is take a pre-op and an immediate post-op of the patient with my smartphone. I then use an app called PicFrame to combine these two photos so I can show the patient how they look right after surgery. They are usually delighted to see the results immediately. With that, in behalf of the PAO and Psoprs, I would like to thank the members for listening to our PAO Lockdown series. Please stand by for the lecture series on genetic diseases in your clinic, what you'll see and should do immediately after this lecture. Thank you.